Our lecture today is about a patient with multisystem affection. I am Dr. Iman Khalifa, Lecturer of Pediatrics, Faculty of Medicine, Helwan University. Today we want to learn what are the diagnostic criteria for SLE. And we want to know how to distinguish from the other types of pediatric rheumatological diseases and recognize the complications of SLE. Our case today is a 15-year-old girl who is seen in the pediatric clinic with a 1-week history of intermittent fever, ranging from 37.9 degrees centigrade to 38.2 degrees centigrade and a rash. يعني عندها حرارة بتطلع وتقعد شوية عالية وبعدين تنزل للطبيعي تاني. The rash itches slightly and is located on her cheeks and over the nose. It appeared when she started playing football with her school team. She and her mother initially believed it was a sunburn, but it has not resolved. The girl also reports 2 weeks of malaise and 8 out of 10 pain in both of her metacarpophalangeal joints. يعني malaise يعني مش حاسة إن هي عيانة وتعبانة, not herself يعني. فهي عندها pain في المetacarpal joints بتاعت الهاند 8 out of 10 يعني very severe. وعندها rash على الcheeks والnose. The joint pain is usually in the morning and the metacarpophalangeals feel very stiff for about 30 minutes. The discomfort resolves with ibuprofen. Yani she has morning stiffness in her joints. 1 month ago, she had bilateral knee pain that spontaneously subsided after 2 weeks. She denies any otalgia, أي ألم في الأذن, sore throat, cough, abdominal pain, or vaginal discharge, but reports that she has right-sided chest pain with deep inspiration. يعني عندها ألم في الصدر على الناحية اليمين لما بتاخد نفس عميق. Her blood pressure is 150 over 90 millimeters mercury. Her heart rate is 90 beats per minute. She has 2 small painless ulcerations on the buccal mucosa. She has hepatomegaly, splenomegaly, and bilateral mild swelling in the metacarpophalangeal joints. A chest X-ray was ordered, which shows a small right pleural effusion. A complete blood count shows a white blood cell count of 2,500 per millimeter cube, hemoglobin 9 grams per deciliter, and platelets 80,000 per cubic millimeter. Her direct Coombs is positive, and her urine analysis shows trace blood and 4+ protein. On microscopy, she has red blood cell casts. Hepatitis serologies and HIV enzyme-linked immunosorbent assay are negative. Basic labs are notable of a total lymphocyte count of 5,000 per cubic millimeter, a creatinine of 1.6 milligram per deciliter. Urine analysis shows red blood cell counts and 4+ proteinuria, and a 24-hour urine returns at 4.2 grams per day. Autoantibody testing is notable for a positive antinuclear antibody at a titer of 1 over 640 with diffuse homogeneous staining pattern, the presence of high titer double-stranded DNA antibodies, the presence of anti-Smith antibodies, and hypocomplementemia. يعني الانتي نيوكلير عالي وعندها high anti-double-stranded DNA وanti-Smith antibodies والcomplement level واطي hypocomplementine. وظائف الكلى عالية شوية 1.6 وعندها بروتين في اليورين proteinuria. What is the most likely diagnosis? What is your differential diagnosis and what are the diagnostic criteria for this condition? And what are the possible complications of this condition? To summarize, this is a 15-year-old girl who has an acute history of fever, facial rash, malaise, and bilateral migratory arthralgias. Physical examination reveals an adolescent who is hypertensive with erythematous macules over the malar aspect of the face, ulcerations on the buccal mucosa, swelling of the metacarpophalangeal joints bilaterally, and hepatosplenomegaly. Chest X-ray reveals a pleural effusion that, combined with her symptoms, indicates pleuritis. Laboratory examination shows proteinuria and a CBC with leukopenia, hemolytic anemia, and thrombocytopenia. So, what is the most likely diagnosis? Systemic lupus erythematosus. Systemic lupus erythematosus is the prototypic multisystem autoimmune disorder with a broad spectrum of clinical presentations encompassing almost all organs and tissues. ممكن يأثر على كل أعضاء الجسم, such as the skin, joints, lungs, heart, kidneys, and nervous system. The term lupus, Latin for wolf, was first used during the Middle Ages to describe erosive skin lesions evocative of wolf's bite. Involvement of the kidneys by lupus nephritis is one of the most severe clinical manifestations observed in individuals with systemic lupus erythematosus. Lupus nephritis is more frequent and severe in pediatric patients and has been associated with higher morbidity and mortality rates. The etiology is multifactorial and includes genetic and environmental factors. The involved pathophysiological mechanisms include decreased immune tolerance, production of antibodies, deposition of immune complexes on target tissues, and activation of the complement system. Although there is a female predominance of this disease in adolescent and adulthood, there is an equal gender distribution in children. What is your differential diagnosis? Systemic lupus must be differentiated from other polyarticular diseases, such as systemic onset juvenile idiopathic arthritis or Still's disease. It must be differentiated from other connective tissue diseases, like undifferentiated connective tissue disease, primary antiphospholipid syndrome, idiopathic thrombocytopenic purpura, drug-induced lupus, and autoimmune thyroid disease, in addition to mixed connective tissue disorder and overlap syndrome. In patients presenting with fever and splenomegaly and lymphadenopathy, it must be differentiated from infectious diseases such as sepsis, Epstein-Barr virus, parvovirus B19, and endocarditis, or malignancies such as leukemia or lymphoma. In case of lupus, with localized or generalized lymphadenopathy or splenomegaly, the size of the lymph node rarely exceeds 2 centimeters, while splenomegaly is mild to moderate. In patients presenting with neurological symptoms, infections of the CNS, cerebrovascular accidents, or immune-mediated neurological diseases such as multiple sclerosis or Guillain-Barré must be considered. In patients presenting with pulmonary renal syndrome, the disease must be differentiated from ANCA-associated vasculitis and other causes of glomerulonephritis, such as post-infectious glomerulonephritis, membranoproliferative glomerulonephritis, or renal vasculitis. This is a table showing the differential diagnosis of systemic lupus erythematosus with distinguishing features and diagnostic approaches. How do we differentiate it from other causes? For example, in adult onset still disease, distinguishing features are arthralgia, fever, lymphadenopathy, and splenomegaly. Diagnostic approach tests for elevated ESR, leukocytosis, and anemia. In case of endocarditis, there is arterial emboli, arthralgia, fever, heart murmur, and myalgia. Diagnostic approach, positive echocardiography, findings with vegetation on heart valve, positive blood culture. What are the diagnostic criteria for this condition? Our patient has 8 of the possible 11 criteria required for the diagnosis of SLE. To establish the diagnosis, the patient must demonstrate 4 of 11 features of SLE, which includes malar rash, discoid rash, photosensitivity, oral or nasal ulcers, non-erosive arthritis, serositis, renal disease, neurological dysfunction, hematological abnormalities, abnormal antibodies, and a positive anti-nuclear antibody. في الذئبة الحمراء أو اللوبس classification criteria عملوها الأمريكان College of Rheumatology, developed a classification system سنة 71 وبعد كده بقت modified سنة 1982 وبعد كده بقت modified تاني سنة 1997. عملوها علشان يسهلوا على الكلينيشنز the ability to identify the disease. وفيها 11 criteria. لو العيان fulfilled 4 من ال 11 يبقى ممكن نقول إن العيان ده most probably عنده systemic lupus erythematosus. ففي diagnostic criteria for systemic lupus ال ACR criteria, ال American College of Rheumatology criteria, وفي ال SLIC criteria اللي هي the Systemic Lupus International Collaborating Clinics. عاملين criteria برضو نمشي عليها. هم تقريبا نفس الحاجة. Serositis أو hematological manifestations وimmunological manifestations وmusculoskeletal ونeuropsychiatric ورينال وسكين وميوكوزال. هم تقريبا نفس الكرايتيريا بس محطوطين بطريقة مختلفة. To establish the diagnosis, a patient must demonstrate 4 of the 11 criteria. In case of the SLIC classification, the patient must fulfill 4 or more of the criteria, at least 1 clinical and 1 laboratory, or biopsy-proven lupus nephritis with positive anti-nuclear or anti-DNA. يعني either fulfill 4 or more, at least 1 clinical and 1 laboratory، أو العيان يعمل renal biopsy proven إن هو عنده lupus nephritis بالإضافة إن عنده positive anti-nuclear or anti-double-stranded DNA. هم مقسمينها لclinical criteria وimmunological criteria. الclinical 11 والimmunological 6. الclinical acute cutaneous lupus, chronic cutaneous lupus, oral or nasal ulcers, non-scarring alopecia, arthritis, serositis, renal, neurological, hemolytic anemia, leukopenia, and thrombocytopenia. Immunological, anti-nuclear antibody, anti-double-stranded DNA, anti-Smith, anti-phospholipid antibody, low complement C3 with C4 with CH50 with direct Coombs test. Do not count in the presence of hemolytic anemia. What are the possible complications of this condition? Nephritis in SLE causes hypertension and can result in renal failure, a common cause of mortality in the disease. Infection due to immunosuppression or the disease itself can also cause morbidity. Cardiac and pulmonary involvement increase morbidity, and long-term complications include avascular bone necrosis secondary to corticosteroid use. عشان العلاج الأساسي بتاع systemic lupus corticosteroids بيبقى فيه مضاعفات في العظم later on. What are the typical features seen in this patient that are helpful in making the diagnosis of SLE? ايه الحاجات اللي ساعدتنا في تشخيص ال SLE في العينة بتاعتنا؟ Fatigue is very common in SLE in about 80 to 100%, but non-specific. Other etiologies should be considered. Mucocutaneous lesions occur in 80% of patients, including acute cutaneous lupus, particularly malar, rash, and oral ulcers. Cytopenias are common, particularly lymphopenia. Renal involvement occurs in more than 50% of patients. Diagnostic clues include proteinuria, hematuria, and RBC CAS as evidence in this patient. So, what are the next steps in the management? Patients with suspected lupus nephritis should undergo renal biopsy. Pathology yields important information regarding prognosis and helps guide therapeutic decisions. يعني العيانين اللي بيجوا manifesting by renal symptoms لازم نعمل لهم renal biopsy علشان نشوف by histopathology the class of lupus nephritis اللي عندهم. العيانة دي عملنا لها renal biopsy طلع عندها class 4 lupus nephritis. The decision was made to start mycophenolate mofetil at a dose of 1,500 milligram twice daily orally, along with prednisone 60 milligrams daily. Acceptable first-line therapies for active class 3 or 4 lupus nephritis include mycophenolate mofetil or cyclophosphamide, in addition to high-dose corticosteroids. يعني الacceptable إن لو العيان عنده class 3 or 4 lupus nephritis إن إحنا نبتدي له either mycophenolate mofetil orally or cyclophosphamide اللي هو الاندوكسان ودي intravenous بالإضافة إلى high dose corticosteroids علشان لازم نعملهم بعنف علشان ما يؤديش ده إلى renal failure later on. عايزين نقول نوت إن نبتدي الجرعة بتاع المايكوفينوليت بدوز صغيرة وبعدين نعلى للدوز اللي احنا عايزين نديها في الآخر. Initiate with lower doses of mycophenolate to minimize diarrhea and nausea with rapid titration to the final dose as tolerated. بالإضافة للمايكوفينوليت والكورتيزون, she also begins therapy with hydroxychloroquine. Hydroxychloroquine is recommended for all patients unless there is a contraindication to or intolerance of the therapy. العينة بتاعتنا ضغطها كان عالي وكان عندها renal proteinuria. But this patient is also started on ACE inhibitor to reduce urinary protein excretion and control hypertension. We also give this patient calcium and vitamin D for bone health and omeprazole for gastric protection in the setting of prednisone use. Just to revise the clinical features of lupus اللي احنا بندور عليها, فالmucocutaneous features include the malar butterfly rash, which is an acutely يعني بتطلع acutely erythematosus elevated lesion, pruritic or painful in the malar distribution, commonly precipitated by exposure to sunlight على cheeks across the bridge of the nose on the forehead and the chin, but it spares the nasolabial fold. It spares the nasolabial fold. ممكن يجي في صورة discoid lupus, ممكن يجي في صورة alopecia اللي هو defined as exaggerated hair loss, ممكن يجي photosensitivity اللي هو development of the rash when exposed to ultraviolet radiation, أو يجي في صورة oral ulcers and nasopharyngeal ulcers, usually painless. فدي صور للمالر راش وللأورال ulcers على الهارد باليت. alopecia, وفي لو discoid lupus ممكن يدي scarring alopecia في السكالب. ودي acute cutaneous rash برضو after exposure to the sun على الترنك. In addition, there is musculoskeletal features, arthritis, usually of the small joints of the hands, but any joint may be involved. Joint involvement is classically described as non-erosive, non-deforming. Myositis or myalgias, آلام في العضلات, with muscle weakness and muscle fatigability may occur. This is correctable deformity in the small joints of the hand, but this is in an older patient. This is called Jacquard's arthritis. Renal features occur in 50 to 70% of children and is the major cause of morbidity and hospital admissions. Immune complex formation deposition in the kidney results in intra-glomerular inflammation with recruitment of leukocytes and activation and proliferation of resident renal cells. Most probably, البروتينوريا بيبقى more than 500 milligram per 24 hours. ممكن يبقى فيه cellular casts, RBCs, granular or tubular casts. And the patient may present with nephritis, nephrosis, uremia, and hypertension. With regards to the nervous system, the patient may present with personality disorders, stroke, peripheral neuropathy, chorea, depression, migraine headaches, psychosis, generalized or focal seizures. أي حاجة من دي ممكن تحصل. With seizures are also associated with the presence of anti-phospholipid antibodies. الانتي-phospholipid antibodies لما بتبقى عالية بتسبب thrombosis في حتت في الجسم، فده ممكن برضو يأفكت البرين ويعمل لنا generalized أو focal seizures ده. فممكن في severe neuropsychiatric lupus present with thrombosis in the sagittal sinus أو acute transverse myelitis. الكارديوفاسكولار features ممكن يجي pericarditis أو pericardial effusion أو tamponade. ممكن يجي myocardial involvement. ممكن يجي premature atherosclerosis and valvular heart disease. ممكن يجي Liebman sac endocarditis, which is a form of non-bacterial endocarditis. Pleura and lungs. Pleuritis is the most common, with or without pleural effusion, وممكن يجي pneumonitis. Pleuritis وبريكارديتس ده اللي هو السيروسايتس اللي موجود في ال classification criteria. ممكن يبقى فيه الليمفادينوباثي والسبلينوميجالي, which are typically soft, non-tender, discrete, and usually detected in the cervical وaxillary وinguinal area. وممكن يبقى فيه سبلينوميجالي، قلنا ما بيبقاش السبلين كبير قوي, particularly during active disease. Hematological features are common. They may present by anemia, leukopenia, thrombocytopenia, and the antiphospholipid syndrome. الأنيميا ممكن تبقى سببها anemia of chronic disease أو ممكن يبقى سببها autoimmune hemolytic anemia أو blood loss، أو ممكن الأنيميا تكون نتيجة ل renal insufficiency أو medications أو infection. SLE patients may have a positive Coombs test without overt hemolysis. Leukopenia, a total white blood cell less than 4,000 per millimeter cube, with lymphopenia less than 1,500 per millimeter cube. يبقى ممكن يبقى في ليوكوبينيا وليمفوبينيا، الليمفوسايتس تبقى عددها قليل. ممكن يبقى في thrombocytopenia with a platelet count less than 100,000. ممكن idiopathic thrombocytopenic purpura يبقى the first sign of SLE. العيانة presents with idiopathic thrombocytopenic purpura followed by symptoms as long as many years later. يعني الأعراض بتاعة اللوبس تبتدي تظهر بعديها بسنين. not at the same time of the idiopathic thrombocytopenic purpura. فلو العيانة دي في ال adolescent age لما بيحصل hormonal changes بيبقى الواحد عايز يفرق is it a simple idiopathic thrombocytopenic purpura ولا is it the beginning of lupus. فبنبعتها تعمل anti-nuclear antibodies و anti-double stranded DNA because there is a possibility that there is an underlying SLE, not a simple idiopathic thrombocytopenic purpura. زي ما قلنا الانتي فوسفوليبيد سيندروم ده بيؤدي الى ثرومبوزز، فممكن يحصل ثرومبوزز في الديجيتس وممكن يحصل رينودز فينومينا رينودز سيمبتومز. فلو حصل ثرومبوزز في الديجيتس ممكن يدي multiple repeated digital infarctions ويبقى الايد شكلها بالطريقه دي with scars and hyperpigmentation. يبقى الانتي فوسفوليبيد ده بيعرض العيان ان يجي لهم ثرومبوزز في البلاد فيسلز وتسبب vasculitis. البرايمري antiphospholipid syndrome, these are antibodies which lead to an increased risk of arterial and venous thrombosis and can be detected by the presence of anti-cardiolipin antibodies, a false positive venereal disease research laboratory VDRL test, and a prolonged activated partial thromboplastin time. لما بنشك ان ده ان في antiphospholipid antibodies بنعمل anti-cardiolipin IgG و IgM واللوبس anticoagulant. لو دول طلعوا عاليين يبقى ده ماشي مع antiphospholipid syndrome والعيانة دي محتاجة تاخد aspirin علشان نقلل الثرومبوزز. هنا في نتيجة للثرومبوزز والفاسكولايتس حصل gangrene with a level زي الشراب كده. gangrene with a level وده livido reticularis في حالات الانتيفوسفوليبيد سيندروم. الجلد كده بيبقى مزقرش، ده اسمه livido reticularis. also vasculitis في الهاندز. Liver and GIT symptoms can be in the form of pancreatitis, mesenteric arthritis, serositis, hepatomegaly. The term lupoid hepatitis was formerly used to describe autoimmune hepatitis because of clinical and serological similarities to SLE. Autoantibodies may help to distinguish between autoimmune hepatitis and liver disease associated with lupus. As antinuclear antibodies can be seen in both disorders, but anti-smooth muscle and anti-mitochondrial antibodies are not common in SLE, and usually when found are in low titers. The absence of these antibodies and the presence of anti-ribosomal P protein antibodies could be suggestive of lupus hepatitis. يعني لما بنبقى حيرانين ده autoimmune hepatitis ولا liver disease associated with lupus وفي الاثنين الانتي نيوكلير antibody بتبقى عالية، نعمل الانتي سموث muscle والانتي mitochondrial antibodies اللي هي ما بتبقاش commonly elevated في ال SLE بس بتبقى elevated في ال autoimmune hepatitis. Ophthalmic features. Up to 8% of SLE patients develop inflammation of the retinal artery during the course of their disease. An equal number of patients have infarction of the retinal vasculature secondary to antiphospholipid antibodies. Also, episcleritis and Zika syndrome. العين تبقى ناشفة. As regarding to the reproductive system, SLE may affect the fetus in several ways, especially if the mother has history of lupus nephritis, anti-phospholipid, anti-Ro, or anti-La antibodies. These conditions are associated with increased risk of miscarriage, stillbirth, premature delivery, intrauterine growth restriction, and fetal heart block. يعني الأم الحامل اللي بيجي لها repeated miscarriages بنعمل لها anti-phospholipid antibody. ده من أسباب repeated abortions أو miscarriages. والعيانة اللي معروف إن هي SLE وجت اتجوزت وحملت، دايما بنعمل لها الانتي رو والانتي لا antibodies علشان if they are elevated في the possibility إن الطفل يجيله neonatal lupus اللي هي الخطر عليها اللي هي اللي بنخاف عليه اللي هو complete heart block. فneonatal lupus is a passively transferred autoimmune disease that occurs in some babies born to mothers with anti-SSA Ro and or anti-SSB La antibodies. The most serious complication in the neonate is complete heart block, which occurs in up to 2% of such pregnancies. Isolated skin rash occurs in a similar percentage. يعني ممكن الطفل يجيله complete heart block أو يبقى عنده skin rash. Once a woman has given birth to an infant with congenital heart block, the recurrence rate is about 15%. So what is the treatment of systemic lupus? Corticosteroids, either oral or intravenous, is the mainstay of treatment. هو الأساس بتاع التريتمنت بتاع ال SLE, corticosteroids. مهم جدا ال sunscreen and avoidance of prolonged direct sun exposure علشان الشمس ممكن تساعد على الفلير of the disease. مهم ان احنا ندي للعيان ده كالسيوم وفيتامين دي to reduce the risk of osteoporosis from prolonged corticosteroid use. Hydroxychloroquine is helpful to control skin and joint manifestations and improve the outcome in all SLE patients. يبقى corticosteroids, sunscreen, hydroxychloroquine, non-steroidal anti-inflammatory drugs for mild arthralgia and arthritis. فحالات لو في joint manifestation بنحب ممكن ندي methotrexate injections أو tablets أو لو في عندنا hematological manifestations ممكن ندي azathioprine. المايكوفينولات والموفيتيل والسايكلوفوسفاميد are used in cases of renal and neurological affection, which are more serious affections, renal and neurological. So, to summarize, systemic lupus erythematosus is a multisystem disease characterized by large amounts of circulating antibodies, both non-specific and specific autoantibodies, which form an immune complex that becomes trapped in the microvasculature, leading to inflammation and ischemia. The most serious features of systemic lupus are nephritis and central nervous system involvement, which can lead to long-term morbidity. Other features include malar rash, discoid rash, photosensitivity, mucosal ulceration, arthritis, myositis, and hemolytic anemia. Because the features are non-specific, diagnosis is made based on specific criteria, including the presence of specific autoantibodies, such as anti-nuclear antibody and anti-double-stranded DNA antibody. Corticosteroids have been the mainstay of treatment for SLE. For more aggressive disease, such as renal and central nervous system disease, medications like cyclophosphamide may be used. In patients for which steroids cannot be reduced, steroid-sparing agents such as methotrexate, mycophenolate mofetil, or azathioprine can be used. Long-term outcomes in SLE have improved significantly and are determined primarily by the presence or absence of nephritis or neurological involvement, with most patients living well into adulthood. We must remember that early detection of lupus nephritis is of essence, since renal involvement may decrease the 10-year survival by 88%. According to the guidelines established by the Systemic Lupus International Collaboration Clinic, SLIC, in 2012, lupus nephritis may occur in patients diagnosed with SLE or lupus nephritis alone. The diagnosis of SLE requires patients to present at least 4 of the criteria defined by SLIC, including 1 clinical and 1 immunological, not necessarily occurring simultaneously. يعني كل المانيفستيشنز بتاعة اللوبس مش لازم تحصل كلها في نفس الوقت. ممكن تحصل يعني ورا بعضها. Renal involvement in patients with SLE is defined by a 24 urinary protein more than or equal to 500 milligram, or urine protein to creatinine ratio of more than 0.5, or red blood cell counts in urine. A possibly ideal additional criterion is renal biopsy showing immune complex mediated nephritis with complement deposition associated with varying degrees of cell injury. Renal biopsy must be ordered whenever lupus nephritis is suspected. In order to be diagnosed with lupus nephritis alone, patients must have renal biopsy findings consistent with lupus nephritis, along with high levels of anti-nuclear antibodies and or increased circulating levels of anti-double-stranded DNA antibodies. يعني لو العيان عنده proven lupus nephritis by renal biopsy بالإضافة إلى high levels of anti-nuclear و increased circulating levels of anti-double-stranded, ممكن نشخص إن ده عنده systemic lupus من غير ما يكون عنده بقية الكرايتيريا. السيرولوجيكال تيست اللي احنا بنشخص بيها اللوبس anti-nuclear antibodies is the ideal screening test because of its sensitivity and simplicity. The specificity of anti-nuclear antibodies for SLE is low, since they are found in many other conditions such as scleroderma, polymyositis, dermatomyositis, rheumatoid arthritis, autoimmune thyroiditis, autoimmune hepatitis, infections, neoplasms, and in addition with many drugs. Also, some healthy individuals test positive for anti-nuclear antibodies. In contrast to the low positive predictive value of anti-nuclear antibody testing, a patient with a negative test has less than 3% chance of having SLE. Thus, a negative anti-nuclear antibody test is useful for excluding the diagnosis of SLE. However, in the presence of typical features of lupus, a negative anti-nuclear antibody test does not exclude the diagnosis. المهم إن it's an ideal screening test. If it's not present, this gives us يعني فكرة إن العيان ده احتمال كبير ما يطلعش لوبس. بس لو الكرايتيريا كلها ماشية مع لوبس والنيجاتيف anti nuclear, this does not exclude the diagnosis. Antibodies to double-stranded DNA are found in up to 70% of SLE. وبرضو specific antibodies include the anti-Smith antibodies are detected in 10 to 30% of these patients and are pathognomonic for SLE. يبقى الواحد يعمل الانتي نيوكلير antibodies, الانتي دبل ستراندد DNA والانتي سميث. وطبعا الانتي فوسفوليبيد antibodies اللي هو الانتي كارديولايبين IgG و IgM واللوبس انتي كواجولانت. ومهم نعمل برضو ال C3 وال C4 وال CH50 علشان نشوف ال complement consumed ولا لا. This is a patient with malar rash. Thank you.